I just want to thank everybody for attending, those in person and those online, because I know how cold it is outside. So I really do appreciate your turning up. And I wish to thank Dr. Soon Song for giving up some valuable time to come and give a talk to us this evening. And also, I think we've got the Deputy Lord Mayor, is that correct?
Yes. Yeah.
Okay, I haven't got your name, so I do apologise for that. And I'll introduce Dr. Song first. So, Dr. Song has been recognised by Diabetes UK as a clinical champion. He recommends early intervention, encouragement for everyone at risk of diabetes, and has extensive experience of helping people affected by the risks of diabetes. He's also one of our local diabetes consultants, and I often see him walking up and down the corridors of the Northern General, although I don't always wave to him. He's leading the hard work to help people avoid type 2 being that they're diagnosed sooner, be supported to get into remission, and when that isn't possible, to live long, healthy lives with diabetes through education, good nutrition, and learning from research, experience using effective medication, peer support, and community engagement, which I think everybody knows that peer support is one of the most important things. So I'm going to hand over to you, Dr. Song, and thank you again.
Shirley, and I think Councillor Sangar is going to speak first on behalf of the council. We just welcome Councillor Sangar.
Right. Thank you for inviting me, and it's really important to have various peer support groups in terms of various conditions. But clearly, we're here today because it was World Diabetes Day, November the 14th, which was the birthday of Dr. Frederick Banting, who I understand was the Nobel Prize winner, who was one of the team led by Professor John McLeod, who first discovered and refined insulin in 1921 and began to save the lives of people with type 1 diabetes. Obviously, those of us of a certain age, British Shepherd sometimes, we think of Fountain down the road in Jarvis Cocker's phrase, at the end at the top of Fargate. Well, see, that was named after Sir Stuart Goodwin, and Sir Stuart Goodwin was an industrialist and a philanthropist, and he was the first person to be treated with insulin and relatively successfully. For those of you who had a confusion of my name, I say my name's Andrew Sanger, the other Sanger, if you like. Frederick Sanger is the other Nobel Prize winner associated with insulin. So insulin was the first protein sequenced by his method. So 3 things to say very briefly. Firstly, all of our surnames, we can't prove how they're spelled. So you go back into the records into 1841, and my surname is Sangar, his is ER. By the time it gets to the 18th century, Sangers and Sangers completely intermixed. So it's a very old English name, equivalent to the Scottish sangster. It just means a singer. That's all the derivation of the word means. So 2 stories about Fred Sanger. When I was about 12, I remember my father talking about sequencing proteins and using the Sanger method. I thought, oh, it's obviously something he's done. I think when you're sort of 12, you don't realise how big the world of science is, and to realise that Fred Sanger was quite an important figure. And my father was just somebody doing some research into foot-and-mouth disease, but he was a virologist. The second time I came across Fred Sanger was when we were on holiday, and we were staying in one of these country farmhouses, and it just so happened the cottage we were staying in was owned by Fred Sanger's sister, and so I was able to talk to Fred Sanger about sequencing of proteins and sequencing of RNA and sequencing of DNA, which she knew nothing about, because for her it was just her brother. So that's my connection with Fred Sanger. But as I say, I spell it with an A. So in the UK, so going back to the 20s, it was type 1 diabetes that was the real challenge, but in more recent years, it's been the proliferation of type 2 diabetes. So now in the UK, it's 90% of those with diabetes have type 2 and 8% of type 1. And from a Sheffield point of view and a UK point of view, there's a considerable link between poverty and deprivation and the prevalence of type 2 diabetes. And I think the other thing is that members of other communities other than the white community, so the South Asian and the Southeast Asian communities, also have higher prevalence of type 2 diabetes as well. So really important for Sheffield that we work together to get early detection and to do what we can to get people to remission. And I've known friends who've had that early stage of type 2 and been to the doctor and they've been able to get back and control it. Equally, I've spent the day in Barnsley at a conference with one of my colleagues who has type 1 diabetes, and it's completely managed. He has a monitor and he's able to control his blood sugar level. So I just know the importance and the way that the management of diabetes has changed over this last century. So the World Diabetes Day was on the 8th of November, and I'd like to congratulate you all for the gala you held at the Circle on Rockingham Lane. It was very much about hope and optimism. I'm told it was very successful, with attendees saying how much they learned and how it helped them to know the progress going on. Clearly in Sheffield, we're very lucky to have the teaching hospital and both universities, which both carry out a lot of research into diabetes and to helping those living with diabetes. I say at the gala, 3 people spoke of their experiences getting type 2 diabetes into remission. Brady, I don't think he's here, but Professor Tesfaye, work has reduced the number of people needing amputations. I know that's a historic problem of those of diabetes in terms of how often people lose feet or legs. So really important piece of work. And then I'm told that the best in type 2 study investigates ways to reduce the risks of heart attacks and strokes. And the CLEAR study is recruiting participants now to look at how we reduce the frequency of very low blood sugar amongst those with type 1 diabetes. So research is actively going on in Sheffield. So really good news there. I'm told that Professor Sachi and Dr. Salvan and Syed at Sheffield Hallam University are investigating early community diagnosis of foot problems. I know other researchers at Sheffield Hallam are investigating the health benefits of being more active for people with metabolic syndrome and type 2 diabetes. So Sheffield Diabetes UK Group works hard to provide information. So I know that's what you do. You provide information and peer support. Really important. I'm really pleased to be here to support you tonight, see what we can do as a City Council, working with your group, with the 2 universities, with the teaching hospital. I know the particular thing you want us to explore over the next few months is this issue about the care alarms. Could we find a way of moving from monitoring your own blood glucose level, but also getting it onto the citywide alarm, so when somebody's on their own and they have a problem, we can get an automated system. So I know that's something we want to look at. But thank you for inviting me. I'm looking forward to learning a lot more about diabetes and the work of your group. But it's really important condition that we find a way of managing. Science has advanced and medicine has advanced a lot over the last 100 years, but there's still more to do, and it's really important that we support peer support groups where we're dealing with people living with these conditions. So thank you very much for inviting me.
Hi everyone.
Hi.
So I'm Tom, Community and Training Officer here at DGV. DigiBeat is a website and app platform supporting people living with diabetes. So we're commissioned by the NHS, and right now we are commissioned up to 25. So all our resources are up to 25.
Sounds really quiet to me.
Is it quite what in general here or on this?
Yes.
Talk louder.
Yeah, you're
Okay.
your real voice.
My real voice.
Yeah.
So I'm here today to ask you questions about what is important to you living with type 2 diabetes. All right. Like I say, we're commissioned in the NHS. We're a website and app platform, and we have lots of resources. There's education, there's peer videos, lots of different things. And like I say, we're up to 25. But part of that commission now is to grow resources for everyone. Okay, and that's what we're doing for type 1 and type 2. And part of my role is to come to events like this to hear exactly what you guys want as people living with diabetes. And today we're joined by a consultant who will be hearing that, and he can take that back to Sheffield and his wider networks and say, look, this is what people are saying in the community. This is what they want. Okay, next slide, please, David. So there you go, just a little explanation about DigiBeat, which I just said. If we go on to the next one, that'd be great. So some of the things on the DigiBeat app and platform right now, just to show you what we can do for us guys living as adults living with diabetes. So we have a psychology tool, which is underpinned by different therapies and supports people at all different walks of life. There's different topics, including like relationships, how to talk to people, like managing adult life, like what to do in work or things like that. So everyday things that you come across, how you can talk about your rights and entitlements, etc., and how it kind of affects your mental health. We have a peer support button that has lots of events. So like this community, this amazing community, you can then find out. And there was a carb counter. So how many people here carb count their foods? So yeah, half the room. So you know that is very great for people who carb count their foods. So people who live with type 2 and do carb their food, then they can do that. And on there you can search food, you can look at the carbohydrate information, you can look at portion sizes, the nutritional information. What we are going to look at is type 2 diabetes for people that don't carbohydrate. You may look at other values. So do you look at like calories or information about that at times? I'm not too sure. So that's where that could support you. So you'd have an app that could help you with that, or a platform. Okay. Next one, please, David. So this is our website. If you go to our website, young-onset.com, you'll basically be able to see all the resources. And we are developing our new website, so you can have a look at that. Next one, please. And here is just an example of some of the things of how it looks on your app. So you've got all the information, you've got different tasks you do over here. There's an area with your clinic information which connects to your clinic, and they'll have information for you, so they can stick their real documents, they can put any other resources that are helpful. So when they speak to you in clinic, they can put these things on the platform. And then go to the next one. Thank you. Again, I'm only going through this quickly today. We have our structured education, and it covers a lot of different things. You can see there, you know, sports and exercise, IFERS, alcohol, sexual health, you know, emotional well-being. So there's some of the things that we cover in our type 1, and we're looking to extend this into education for type 2 as well. Because how many people here have had education, like physically gone to a place and had education? So 1, 2, 3, 4. 4 people out of 5, maybe 6. 6 people out of probably 20, 30 people here today, you know. And I'm going to ask you a couple of questions in a minute, so be interested, you know. So by having that education is so important, you know. You've been diagnosed, and then having the information, having the education to manage your diabetes, your condition. Thank you, David. We've developed some new resources, like these, for instance. We have some nice PDF posters that explain your medications, your treatments, all the different pathways. So you can see here, it just breaks the information in a nice, easy, understandable way. Whereas, do you ever look at when you get your medication, are you reading all them fine little pieces of paper? It's probably hard to really digest and understand. Whereas we have made it into real lovely ways to present information in posters or video form that you can watch. Thanks, David. And there's some information about annual checks as well. So, you know, it might be a bit overwhelming of what are annual checks, what do they do? You can read up and you can find out some more information about that. Okay, so for anyone that is watching online or in the room, if you've got a smartphone, you can scan this this little survey thing. It will bring a survey on your phone. If not, I'm going to have the questions on the slide. We're going to have a conversation about it. So don't worry, I'm going to include everyone. So if you don't have a smartphone, then that is fine. We'll talk about it. But if you wish to do it, then you can. I can see the survey coming up here as well. So I'll give you maybe 30 seconds to get that. But if not, we will crack on and we will answer it together. I can see people already doing it online or in the room. So the first question, while we're waiting for that, is what is your connection to diabetes? So who has type 1 diabetes here today? So 2, 4, 5, 6. It's about 6 of us. So Claire will write that down. And then is everyone else living with type 2 diabetes?
Yeah.
Yeah? Or is there any other types of diabetes? There's so many different ones, isn't there? Is there any other types, or is it just type 1 and type 2 today? Yeah.
I'm a mogul.
You're a muggle. Do you know what they call you muggles, David?
What?
Type Fs.
Type F.
Friends and family.
Ah, right.
So there you go, you learned something today. So
Okay.
type Fs.
Right.
You know, because at the end of the day, you guys who don't live with diabetes, you may not be physically living with it, but you are living part of it with your partner, your friends or family. You know, you're part of that thing. So if you go into the next slide for us, you'll see that first question. I can see the responses so far. 3 people said type 1, 2 said type 2. No healthcare professionals here today. Well, we have 1. There we go. And no one has said other. So fantastic. I can't get the results on here today, but I've got them here. If you go on to the next question. Okay. Next one. Actually, I've missed off my slides. How long have you been living with diabetes? Pop in the chat. How long have you been living with diabetes? We'll go around the room. We'll start from these guys. Just shout your number. Claire's going to write the number. So I'll start 18 years. We're going to calculate how many people lived experience. None? None? None?
2.
2?
30.
30?
Pre-diabetic.
Pre-diabetic?
I'm in remission, so I'm about a year.
Yeah, we'll take that.
72.
72. Brilliant.
20.
20.
30.
30.
20.
20. 30. Vince?
61.
61.
12.
12. I said 18.
5 online.
And 5 online.
I'm one
Fantastic.
pre-diabetic.
And I can see people here, 23 years, 8 years, 8 years, 61 years, 2 years, 61 years. Claire, have you got all that?
No.
So I reckon that must be, including our very fantastic numbers, I reckon it must be about 400, maybe 300-400 people. So I reckon yourself a round of applause. I think, you know, living with diabetes is relentless. You know, all the decisions that we're making. Have you ever heard that thing that we're making 180 decisions all the time? You know, and there's so many things that can impact your levels all the time. You know, stress, exercise, anything, you know, as well as what you eat and things like that. So, you know, it is relentless. It's 24/7. We don't have a break, do we? There's no on-off button, and we can just turn it off. You know, there's fantastic things like the remission from type 2s, and you know, but not everyone will get that, unfortunately. But so well done to you, sir. Well done.
Still have to fight for it.
You probably do. Next question, please, David. So, what do you use? Is that the one? Go back up a little bit. Yours has gone a bit funky. Don't worry. I'll ask the question. What do you use when you need support guidance from your diabetes? So I've got a few options, but I'll let you guys shout them out. What do you use when you need support or guidance? Write in the chat or put it on the survey. What do you use?
Books.
Books?
Yeah.
Leaflets? Doctors, nurses, yeah.
Other people with the condition.
Yeah. Community people, yeah. Anything else?
Type 1 support group, it says here online.
Type 1 support group, fantastic.
And internet.
Internet, This amazing community, Lindsay and everyone's part of. Anything else?
I use Reddit.
Reddit, yes.
It's brilliant community.
Yeah. It's finding community, isn't it? So, few options. We've got 3 people that said diabetes team, 1 social media, 1 friends and family, 3 set of community. So, you know, it's different ways that we can get support. And it's so important because you don't want to be alone. You know, it's a hard condition, as we just said, is relentless. So having other people that get it and you can talk to in both a healthcare professional capacity, but also other capacities is important. But it's also important, guys, as you will know, it's getting the right information, you know, like there may be places that aren't the best of places, and we know how technology is advancing, like you said, but you know, you could go in AI, like ChatGPT, type something in, but is it accurate? Is it safe? You know, whereas things what we're doing digitally, everything we do, just one example, is clinically approved. We work with a team of healthcare professionals across the country to make sure all the resources are accurate, safe, you know, whereas, you know, AI, you just don't know, do you? Just don't know what anyone could say and people may follow it. And if they do that, that's their decision, isn't it? So, no, that's great. Thank you.
Is there, what about people who don't know anyone else who's got it? I wonder, or don't have internet.
Well, yeah, you know, who do they reach out to? Yeah, who do they reach out to? Probably no one really, isn't it? Like maybe the doctors, maybe, but that's a different relationship, isn't it? It's a different relationship from a friend or family or community or asking on Reddit. You know, it's a different. You know, we're the ones that live with it all the time. So yeah,
A lot of the doctors have health coaches and stuff, though.
Hey?
The doctors, a lot of the surgeries have health coaches.
Yeah. So you know, hopefully there's people to talk to, isn't it? But then you know, hopefully it's hard to like, you know, how do you engage these people that don't know about these things? I don't know the answers. You know, maybe there needs to be more campaigns on TV where you see Diabetes UK adverts pop up. I don't know, you know, and then people go to the website and find information, or you know, it is hard, and we need to help with that, don't we? I'm going to skip this question. I'm going to move on to the next one. When you're looking at resources, what do you guys prefer? Do you prefer animations? Do you prefer hearing real people? So that's like us talking, sharing stories. Do you prefer posters and PDFs so you can read things on booklets and things? Do you like text, just seeing the plain text? Or do you like resources like links, like go into apps and stuff? Like, what do you guys like? Please fill it in online. But what do you guys like to help you? What do you like?
Text.
Text, yeah, reading stuff, yeah.
Especially if I'm copy and pasting it.
Yeah.
I like animations. I find they're quite easy to follow.
Yeah. And would you say very short and snappy to the point rather than ending it, so it's a bit boring, you kind of lost focus of what it's about?
I've got ADHD and dyslexia, so reading is not the best thing for me, but
Yeah.
I'm good looking at things.
Yeah.
And also I think peer videos are a good thing.
Yeah. You know, hearing someone's story, you know.
Well,
relatable.
David and I are volunteers at a primary care network, and we share our stories
Yes.
among other patients who are suffering type 2 diabetes.
How amazing is that? You know, other people can then watch it and relate to it and, you know, normalize it. You know, I've been type 1 for 18 years. For 15 years, I was alone, embarrassed, blamed myself, didn't talk about it, hid it. I used to be a teacher for 8 years. Now I work for an organisation, you know. But 3 years ago, I wouldn't be anywhere near this. You know, the reason I'm here today actually is because technology changed my life. I had COVID, I had a letter through the post to say you can go on technology now, and that changed my mindset. And you know what the biggest thing for me, guys, I don't know about you guys, is mental health. That changed my mental health like that. And everything else has kind of fallen into place, because when I started feeling better about my mental health, my diabetes, everything else kind of ticked along. And then eventually I stopped blaming myself. I accepted it, didn't feel guilty anymore. I understood it. You know, I probably had diabetes burnout for many years and didn't even know what that was. There's no one talked about it. My diabetes team never referred me to a psychologist, you know. And in my personal life now, I've not seen a nurse in about 5 years, I'm being honest with you. But through education and peer support and all them sort of things, I feel okay, you know. So yeah, people are saying links, peer videos, text, I mean, everyone's saying everything, so fantastic, thank you. Rank these resources in order. Let's have a look at this quickly.
Oh, sorry. Next slide.
Next slide, boss. So here are just some suggestions, but we.
Be me.
Looking at these resources, I've just put a handful down, but is there any of them resources that you would rank as #1 out of that list there? In terms of type 2? Emotional wellbeing. Does anyone agree or disagree? Please tell us. Like, do someone go higher, or you know? And these are just some examples. I'm going to ask you in a minute what your examples are.
I
But
think newly diagnosed is important to get it as soon as possible.
get
Get
the
as
right
much support
information.
as possible to figure what's going on and
Yeah,
how
yeah,
to change before it gets worse.
yeah, definitely. Yeah, have the right toolkit, because you can't do the job if you don't have the right toolkit. You know, it's like, yeah, you're type 2, but okay,
Yeah.
what do I need to do now? What, you know, do I need to share about levels? Do I need to do this? You need that toolkit to inform you to make the best decisions possible, right? That might be me, I don't know. We're looking at that emotional wellbeing, top of the list, type 2 awareness, prevention, treatment information, so all them resources I showed you, sports and exercise, healthy eating. Newly diagnosed, no one actually, interestingly. Relationships right at the bottom as well. Okay, last question, I believe, is what resources and information is important to you? So as you as adults living with type 2 diabetes, and someone here top, is what resources and information is important to you? I showed you a few slides ago about alcohol, sports and exercise, all them sort of things. What do you want? What information do you want or find helpful now and you need? Like, what's important?
I think those things, you know, you get them for type 1, where you get the constantly tell you which way you think to get you an idea.
CGM.
CGM. It's a shame you can't get it for type 2, because I think it's really important, because I think type 1 is, you're kind of sort of stuck. You know what I mean? But type 2, you can kind of get into remission if you have the resources to help you get into remission. You know what I mean?
I'm type 2, I have a CGM that I buy it myself. They're very expensive.
Yes.
I'm lucky enough that I can afford it,
Yes.
but it would be wonderful if
Yeah.
more.
And
people-
a consultant friend might be able to expand on
Yeah.
that in a minute. I don't know every bit of it, but I
I
know
would-
like it's very dependent on how your type 2 is, correct? That, you know, if you're on multiple injections and all that sort of thing, you may meet that
That's right.
criteria. Whereas, you know, I believe, and I'm sure you all, I think all type 2 should have CGM, you know, to monitor your.
I was on injections for 10 years and I came off injections. But then I developed prostate cancer, and my hormone injections sent my HbA1c sky high again. So that's when I bought this, and now I'm bringing it back down again because of the rescaling.
And do you like how you're able to see where you're at?
Yeah.
So if you have,
Anything I
I don't
eat,
know,
anything I eat.
chips,
I
pie
can-
and beans tonight or whatever,
Yeah,
you
that-
can see what it's doing.
I've been on low carb for about 12 years now.
Yeah. But it's nice to. be
Very
able to
good.
see.
Yeah, I know every minute of every day what my blood.
And if you have a hypo, you know, you can,
Well, I don't have, but
Yeah.
yeah,
some people do, don't they?
Yeah.
So,
yeah, it's got an alarm,
Yeah,
it's too low, it
yeah,
sets up.
that's good, it's good. What resources and information important to you?
Awareness,
Awareness?
type 2 prevention,
Yeah,
healthy eating,
yeah,
prevention, support group emotionally supportive, how to find strength training, etc. at my level
okay,
with peers and appropriate coaching, technology, sensors, pumps and fitness.
amazing. Thank you to everyone online. We'll get that script from David later on. I'll get all the answers. Because this is really, really helpful. You know, we've got understanding CGM support from the community here. And the last questions is, So today I've talked about what we kind of do at DigiB, and like I say, we're looking in that direction now to support adults through our website and through our app, and having that resource, the education, the awareness, all trustworthy. Is, do you think using AI, whether you use it or just knowing about it, do you think an app like DigiB, a platform, could support your diabetes? So that's the first question. So disagree or agree, is do you think it could support your diabetes or people like you living with diabetes? Do you think it could? Yeah? Yeah. Super. You're probably all going to be nice now and just agree to every single one. If you don't agree, please tell me. Hey?
What does CGP do and how is it, how's it different from the CGM?
So DigiB is a platform to support people. So it's got all different resources on there. So Shirley, so it's got education resources, it's got peer videos, you know, it's
information.
It's information.
Yeah, it's
Yeah,
not
it's information.
CGM,
No, it's not CGM. No. It's an education platform. It's to support people, give them resources and peer support and psychology information, etc.
So
we've
it's a
answered that.
website,
Yeah.
but you can have it on your phone.
You can have it on your phone.
Yeah.
Yeah. It's like we said before. I asked you guys to have your own education, and probably a further room right now. So you know, it's giving people resources that can help them outside of the clinic time. So you know, we may not see our consultants or diabetes team for a lot of the time. You know, I think is it 0.3% of the time we're with our diabetes team. The rest of the time we're on our own, but we feel on our own. So having places like this, not just DigiB, but other places, you know, can be supportive. Diabetes UK, Breakthrough T1D, you know, resource charities or organisations. You know, it may be not your cup of tea, and that's absolutely fine. But there's a lot of people out there that want it and need resources. So yeah. Does that help a little bit?
I have a question. So would there be any translation for any people who
Yes.
may not speak English?
Yes. So on our website, great question. I didn't mention this.
Mm.
On our website, you can translate all our written resources, all our PDFs, all our packs in 99 plus languages. So it's accessible, it's inclusive, and you know, I think that's great. You know, not if you go in the NHS and places like that, I don't think they do that.
Right.
So having what we've got, you know, is fantastic. And on our app, you can translate all the some of the written and some of our videos into, I think it's 13 languages, and they're like the most common languages that are used in the UK. But we're looking to extend that. But all the written content comes, so you know, there's no barriers then. You know, people can translate it, you know, and we hear that so much when I go to events or training around the country, all parts. You know, I was talking to someone the other day and they said, "Oh, have you got Romanian resources?" Yes. You've got Ukrainian resources? Yes. French, etc. You know, we've got it. It's helpful. So, and then stigma at the bottom as well. So important. So I think that is it on my slide today, David. I believe. Just this final thing. If you have a smartphone now or you're watching online, we do have a survey, and Lindsay can put this, or I can put this in the WhatsApp group. Some of you might have done it a couple of weeks ago when you saw me there. It's a survey. It'll take about 10 minutes with more questions, more feedback that will really help shape the future of what we're trying to do to help you guys live with type 2.
So Tom, if we print that and bring it to our next
Yes.
meeting, people who are not online could do
Absolutely.
it.
Yeah. I do apologise. I didn't get time to do that today.
Yeah.
But yes, we can do that between working that out, and then what I can do then is I can pick it up and we can, you know, get that.
Sorry about this. Could you just say what CGM is in case anyone doesn't know?
Yeah. So anyone that doesn't know what a CGM is, it's a device that you have on your arm, and my consultant friend will hopefully help me. It's a device that you have on your arm, and there's different types, different brands that you can potentially have. But you need to speak to your own diabetes team to talk about it. But it's a device that you put on your arm, that you apply it in, and it's got different sort of life expectancy. So it might be like 10 days, I think is
2 weeks.
2 weeks. So, you know, 14 days. So it depends on what type of one you've got. And then essentially it will check your levels, your glucose levels, all right? It will check your levels, and then it will tell you on your phone what your levels are. So let me show you mine. I am blaming that on the hot chocolate. I had screen cream and marshmallows as well, folks. So I'm currently 12.8. So it's telling me what my levels are. So, you know, this is a lifesaver in terms of me being able to manage my diabetes. It then talks to my pump because I'm using a pump, but not everyone is fortunate to have a pump. But it tells me what my levels are, and it will tell me if I'm really high, tell me if I'm going low. It will do alarms if I do go low, and then I can try and treat that. So, you know, it's a fantastic tool, and without this, I would not be here now. I'm generally saying that because that before then, I was finger pricking. Or I wasn't actually, because I was in a phase of complete burnout, being totally honest, you know, for so many years living with diabetes. So it's so important. It's that toolkit to help you manage your diabetes, and it's available for all type 1s. It's part of your care. And type 2s, it's for people who are on like more multiple injections today and that sort of stuff. Answer your question? Yeah. Super. So on there, if you do want to do a survey, please do. We'll distribute paper copies. On the next slide is my email address if you wish to get in contact with me, tom@digibee.org. With that, and then I think the last slide is just to say thank you for your time today. You know, without peer support, you know, it's changed my life, and I will always advocate for it because, you know, no one should live on this journey alone. And my wife, she is great to a certain level in terms of supporting me, and has, and I'm sure she will continue, but she does not get it like we get it. You know, she does not wear them shoes, you know, we do, because we feel it every day, the relentlessness of how we have to manage it. And I think things like what you guys do here is just tremendous. So please keep up the great work, and thanks for your time today. Thank you. And we're just working out the maths of how many years. 1 second. Can anyone have a guess? What do you reckon?
378.
378. Any higher or lower? I feel like I'm Brucey. Any higher or lower?
I think that's a good guess.
345.
489. 489.
500.
Yeah, 500 people. So well done, guys.
489 years.
Yeah.
Yeah.
I mean, between you two and someone else, it's 300. Just 300. Yeah.
They've got one thing on their mind.
What's that?
No, I mean, the very thing.
Yeah.
If nobody can mention you, and you hold the gamble.
Right, so I'll make a start. Hi, I'm Sue, one of the local doctors here, diabetes doctors. So what we'll do is to quite a different talk from Tom, because I'm a bit more medical, more factual. But what I'm going to want to show here is to give some idea of a young type 2. That's my interest. And why we are looking at it nationally as well, in terms of guidelines and what we're doing locally. So what we'll do now is to sort of start off with a case here. Just move the yeah. So this you'll see a 30-year-old female who went to GP with symptoms due to high sugars and some weight loss. And then you have family history of type 1 diabetes, single parent with a young child, non-smoker, and she had a raised BMI, blood pressure is a bit high, trace of ketones, and HbA1c is a bit up. Confirmed diagnosed with type 2 diabetes. So when we are faced with this kind of scenario, what I'm going to do is to tell you, or sort of put you in my mind what I think about. Okay, how do we approach the problem, and why do we do certain things? So the kind of questions that come to my mind clinically is, first of all, is the diagnosis correct? Is this type 2 or type 1? Okay. is very relevant because it's young person, type 1 is a possibility. Second one, if it's type 2, what is the appropriate diabetes treatment to use? Because there's so many agents to use in type 2 diabetes, as you know, but which one do we choose? Thirdly, is this young person in the early 30s. So what is the risk? What is the long-term risk of getting complications? And how do we mitigate those risks or reduce that risk? And what aspects of care should be considered in her case? So this will form the basically skeleton of my talk. So what we do now is to first of all go through basics of how do you define young type 2? What is the clinical characteristics? What do they have? Yeah, compared to the older onset versus type 1 diabetes. And what areas that merit special consideration to the young person with type 2 diabetes? So you're looking at diagnosis, mental health, and pregnancy. And also I'm going to talk briefly about what is the current initiatives that is available now, regionally and nationally, to improve the care of these young people. And finally, I'm going to talk about the NICE guidance. I'm on the NICE committee, and I can answer the question of CGM later, okay? Because I wasn't meant to drop this right. And I'll show you what NICE will be hopefully saying in February 2026 when it's published. So definition is basically age of diagnosis below 40. And two groups, youth onset or childhood onset, which is diagnosed below age 18, and young adult onset, which is diagnosed between 18 to 39. And this is the group I'm talking about. I'm not a pediatrician, therefore I'm staying away from kids, talking about young adults. So what is the size of the problem? It's increasing every year. And this is the National Diabetes Volume data. So in 2023, which is about 2 years out of date now, 1,000 people below age 40 with type 2 diabetes in UK. This is roughly about 5% of the type 2 population overall. A small group, but it's growing. The worrying thing is that the new cases are increasing at a faster rate in the young people. Okay, 39% under 40 versus 25% above age 40. Yeah, it's growing, and we are seeing it clinically now. People in the 20s and 30s coming through not in general, either to the acute medical admissions unit or refer to GP with newly diagnosed diabetes. They are young and they fall into type 2. And most of these people are between 26 to 39. Okay, this is the greatest group that we're seeing now. Yeah, and most of them are under primary care. They don't see it. So in the UK now, among young adults with diabetes between 18 to 39, majority now has type 2 diabetes. Okay. So it's no longer type 1. 10, 20 years ago, below age 40 is type 1, number 1. Okay. Now it's type 2. And we are seeing that antenatal clinic as well, as you can see. And type 2 is no longer a condition of middle age, it's getting younger. So how does it compare the older onset? I think it's a very important question to ask. And we now know they are predominantly concentrated with ethnic minority groups, especially South Asians, African Caribbeans, Arabics, along with obesity, and also find that their pancreas fails far more quickly, far more rapidly. So they're more likely to end up on insulin therapy than the older person. And because they're diagnosed young, they are exposed to adverse metabolic milieu, high sugars, the blood pressure, and normal cholesterol at a younger age. And as a consequence, they develop complications earlier. More importantly, when they are young and chronically productive age. And that's expensive for NHS, isn't it? Yeah, both in terms of medical costs, but also societal costs, loss in work days and so forth, sick days. And they got reduction in life expectancy, 15 years versus 6 years if you diagnose age 50. And certain conditions like pregnancy and mental health are more prevalent in young people. So there's a lot of medications that young type 2, and they usually outside UK. You heard the UK PDS data study, yeah, the type 2 diabetes study that was originated in Oxford in the 1970s that changed the treatment landscape for type 2 diabetes, where they put down, the complication rate is linked to good poor glycemic control for the first time. So in this study, they got a subset of young type 2 in the age 40, about 10% of the study population. And the mean age of diagnosis is about 35 years old. And the follow-up up to 30 years. But the median follow-up on average is about 18 years. And this is the longest follow-up study in the world for young type 2. And what we found is that the longer you have diabetes, the burden of complications, where small vessel disease like retinopathy, neuropathy, nephropathy, and large vessel heart disease, stroke increases. Okay, so the red line is the older onset, blue line is young onset, but it doesn't matter. As you've got more diabetes, both groups increase in prevalence. So we know young type 2 is not a benign condition. So the next question to ask is at what age do complications occur in the diagnosis of a young person? So in Sheffield, the average diagnosis of young adult is about 32 to 33 years old. That's what we see in our data. So, and this data is similar to Hong Kong, which is diagnosed at age 34. Yeah. So if you're diagnosed age 34, by age 60, you're in big trouble. Okay. This is big trouble. Okay. So this young age, I'm almost 60, right? So, and I hope I don't look too old, right? I don't consider myself old at all. But if you're age 60, you've got renal disease, heart disease, and all the types of complications, that's where the cost will accrue in NHS. Majority of the treatment costs in diabetes is not medications. It's actually treating the complications. Yeah. And it's preventing people from getting this problem. And that's the challenge. So what's the reason for the complication early? Yeah. So we now know when you're diagnosed with type 2 diabetes at a young age, they have higher HbA1c, poorer diabetes control, more obese, and worse lipid profile compared to older onset. That's proven. And because they're diagnosed at a young age, they are exposed to this adverse metabolic environment for far longer, yeah, for many years. And I'm going to show you this concept in the picture. I think it's easier to understand the concept in the picture for. So again, this study from Hong Kong, whereby they look at young onset, which is red, and usual onset, blue. Yeah. So age of diagnosis is around 34, and the age of diagnosis is around 54 for young onset. About 20 years different. What it shows here, if you diagnose at a young age, you're exposed to far greater glycemic burden. Yeah, you're exposed to high sugar environment for far longer. And the burden of exposure is three times greater in young people. So it's not surprising that these people will get complications at a young age. And the same concept applies to cholesterol, high blood pressure, and excess weight. You're exposed to this adverse metabolic milieu for a long time. Yeah. And therefore, the lifetime risk of getting complications far greater. Young person. So how does it compare to type 1 diabetes? Yeah. I think it's a very relevant question to ask. And we now know that if you've got type 2 young age, compared to type 1, the type 2 person is more obese, blood pressure is higher, abnormal cholesterol, high burden of certain complications of neuropathy and nephropathy, heart disease as well. And also the retinopathy can be more significant and more severe. But if you look at the mortality rate, people with young type 2 have twofold higher mortality. Okay? This is shown in the Australian group. Black line is the type 2, red is type 1, you see the mortality diverging. So it is a serious condition. despite that, the care that's been given,
Could you go back? That slide, I can't get my head around it, I can't understand it.
which one?
That,
You mean this?
that
The
graph.
twofold part?
The thing with A and it goes from 0 to 60, that diagram can't make sense. of
Okay,
it.
this is duration of diabetes,
It's what?
duration of diabetes.
Okay, yeah.
Okay, so the longer diabetes, so basically from diagnosis, they follow up for many years. Yeah.
Yeah.
And then they follow up people who survived and people who died. So what we call the survival curve. Yeah. So if there's more people dying, for example, then the curve will drop off like a cliff.
Yeah.
Yeah. Whereas better survival means that the curve is less steep. Yeah. So for type 1, it's less steep. So less people were dying compared to type 2, which there's more people dying here because the curve falls the more.
So is that like twice as many who've got the type 2 early will die than if they had type 1?
Correct.
Wow, that's scary.
That's scary. So in the past, people tend to say, was a SHO some time ago now. They always say like, oh, type 2 is benign. Just get sugar, that's it. Type 1 is serious condition. Because why? Because type 1 occurs young, it's dramatic, the way it presents is acute, weight loss, yeah, and then they need insulin. Insulin is a big red flag. Whereas type O is serious, you don't have much symptoms, and here's some tablets, you'll be okay. That was the mindset. I think the UK BDS study changed the mindset when it published, whereby showed that mortality rate is actually bad and glycemia is important.
Does the NHS know this statistic?
I think they know, and I'll show you why.
Okay, sorry. Sorry.
In terms of policies and guidelines,
Yeah.
I'll show you why. We do know that. Any questions on this slide? So what I'm trying to show here is type 2 in terms of clinical characteristics, blood pressure, weight, cholesterol, and then here is the survival or mortality risk. Yeah. Sorry, it's a bit medical, but it shows a good story. So okay, can I move on? Okay, okay. Despite that, the care for young type 2 is not as good as older type 2. And this is from the National Diabetes Audit again, the care processes, the 8 care processes that you need to check. So this is the young people in the red box versus usual onset. You could see the number of people achieving the number of care processes completed is far lower. And this is why we see is South Yorkshire, Sheffield. No difference at all. Okay. I think the reason is quite complicated. It's not just patient related, but also medical related. So it's multifactorial. But what it does mean is that the current model that we have in developed care for young type 2 is not fit for purpose. Yeah, it's not delivering. So we need to look at different ways of how to reach out to this high-risk group in order to engage them better. That's the challenge we are facing now. So special considerations, diagnosis, I think I started this earlier in my talk, where I need to make sure it's type 1 and type 2. Why do we say that? Because the chance of having other types of diabetes in the young age is much higher, especially type 1 and monogenic diabetes. Type 1 diabetes, the age of onset, peak onset is teenagers and kids, yeah, and also young adults. Now we also know type 2, the age of diagnosis is increasing below age 40. So it's getting difficult to differentiate between the two based on age alone. So we need to be certain. And also the clinical features of age, BMI, the way they present is not accurately predict the type of diabetes. Why? Because type 1 can be overweight or obese. Type 2 can be at a young age. And so type 1 does not always present classically as you read in textbooks. They can present very gradually, insidiously, with minimal symptoms. We have seen that as well. clinical practice. And misclassification of diabetes is not uncommon. And this has been shown in the Edinburgh group now. And most of the time, it's the type 2 being misclassified as type 1. They actually got type 2, but they think this is type 1. And as a consequence, they get insulin injections unnecessarily. But more importantly, they're not being given the medication that will prolong their lives, that protect the hearts and kidneys. The GLP-1 agonist and the SGLT inhibitors. And I'll show you the nice guidance as well. If you think of monogenic diabetes, think of family history, especially if you see diabetes occurring in their grandparents, your father, parents, and then the siblings. So each generation is appearing. You need to be found to question, is this monogenic diabetes? And if you read the textbooks again, they say monogenic diabetes usually below age 25. Guess what? I've got a patient of mine. His daughter was diagnosed with diabetes in the 30s, early 40s. And then we did genetic tests, it turned out to be MODY. And because it's MODY, we want to test for family members with diabetes. Her father is a diabetic. So we tested monogenic for him as well, and it turned out to be positive. Guess how old he was when he was diagnosed? Late 60s.
Wow.
Say it.
Late 60s. Okay. So the key thing is diabetes across every generation that occurs. So grandparents, the parents, and the siblings of parents. If you all appearing strong penetration, think of monogenic diabetes, regardless of age.
Excuse me, can I ask, what is monogenic diabetes again? Is that when they have the genetics kind of thing, or is that?
Yeah, it's called MODY, older, maturity onset diabetes of young. So it's a very specific mutation. It's autosomal dominant, means that if you've got one genes have got two pairs, isn't it?
Yeah.
For one of them,
Yeah.
you'll get it because it's autosomal dominant. Okay, and it passes through each generation, like a butter being cut through the butter.
And that's monogenic.
Yeah, that's monogenic. It's very strong family history across generations. Think of that. And now, when we get newly diagnosed diabetes in Sheffield, we do this test, especially the antibody testing, number one. And if you think that's monogenic diabetes, you do the genetic test. So the other bit we need to think about is mental health. It's a big deal. Young people with type 2 diabetes, as now it's evidence-based now. Up to almost half of young type 2 is burdened with mental health conditions, and it's more common in females. And it's difficult because if you're not engaged, got high depression or impaired emotional well, you're not going to engage your lifestyle treatment or your healthcare professionals. And that can lead to poor self and poor outcomes and poor control. So screening for mental health is important. And on this pregnancy, young women with type 2 diabetes can become pregnant. And we're seeing more and more now in the antenatal clinic. And that's now in the national audit. Type 2 is the dominant phenotype in the antenatal clinics. More than 50% is actually type 2 now. And they're from deprived areas, again, ethnic minority groups, not well prepared for pregnancy, poor control on harmful medications like ACE, ARB, statins, and they might be on medication for diabetes, not safe for pregnancy as well. And of course, increased risk of miscarriage and stillbirth. And we know if you have given good preparation of pregnancy, it can lead to better outcomes. Again, that is true for type 1 and type 2. Because 1 in 2 pregnancies are not planned, it's important. All women of childbearing age should be alerted to the fact that they need to think ahead if they do want to become pregnant. They will tell me, oh, I have no plans to become pregnant. And guess what? They're pregnant. So I've seen it so many times. So my diktat is that if you got a woman type 2 diabetes at childbearing age, I would tell her the risk of so that she thinks about it. And reception, of course, is important. So I think for me, the management goals is quite straightforward. It's preventing type 2 diabetes, that is prevention. If you do have diabetes, risk reduction. So it's very simple to say that, but to achieve this goal is difficult. So the strategies for me, the way I think about it is early identification of young type 2 supporters. Almost 1 in 2 of young type 2 are not diagnosed in the community. They do not know that they have it. So unfortunately, there's no national policy to screen for type 2 diabetes under age 40. There is for above age 40, the healthcare checks, but under age 40, there's none. So my view here is that if you have someone who have risk factors for type 2 diabetes in terms of family history, race, BMI, or of a certain ethnic group, then should be checking the HbA1c on blood glucose. It's cheap, it's not expensive. Once you are diagnosed with diabetes, the early and effective treatment with right medication, also lifestyle issues are important. And what we'll show you later, we are using more of certain medication now in type 2 diabetes because it is what we call prognosis enhancing drug, whereby you reduce the risk of cardiac disease and renal disease, because cardiovascular disease are the main risk factor for mortality. So the service models I said to you earlier does not work because we are not achieving the care process that we are achieving. So we need to think outside the box. What can we do differently from the current model we have to improve the care? And that's a challenge. I don't have the answer for it. We have tried different ways and methods, engaging the community, lay members of the public to engage the patients are important, and also understand the cultural barriers as well. From the work we have done in Sheffield is important. So initiatives. So in South Yorkshire, we have now developed a guideline for the oral management of young type 2, which touches upon lifestyle, but also the medication that we should be using. We also have a lipid lowering treatment as well for young type 2. Nationally, for the NDA, the National Diabetes Audit, they are already collecting data on quality of care. And at the moment, there's a quality improvement collaborative whereby they are actually engaging the primary care network, PCNs, to sort of share their learning experiences, how they find about managing young type 2s and sharing good experience and expertise. The NHS England just had the T2 Day program. Have you heard about that? Yeah. So the T2 program was targeted specifically on the young type 2 focused primary care cohort to see where they can improve the care pathway. And finally, NICE guidance has updated the guidance, and it's going to be published in February 2026. Has anyone seen it? Draft guidance? No? Okay, so I'll show it to you. Right, now, it's a huge change from the existing guidelines. Okay, I'm on the guideline committee. We basically decided to say that the existing guideline is not fit for purpose, and it's obsolete. And we need to move with the evidence we have. And also we need to think of subgroups that frontline clinicians like me, and so general practitioners and practitioners see in the day-to-day work. And they should be given guidance if they see a person with certain characteristics, what kind of medication should they be using and why? So they are 1, 2, 3, 4, 5, 6, 7 groups. So you have the low risk, whereby they have no comorbidities, obesity, people with chronic kidney disease, young type 2, heart failure, people with cardiovascular disease, and frailty. So for the first time, we have actually looked at patients' subgroups and then even advise and recommendation what kind of medication we should consider. We have moved away from being glucocentric. All the while, nurses always say achieve HbA1c or certain target. If not, add another medication, another medication, another medication. And I think that's a very obsolete way of doing it. And we have moved away completely and emphasized on heart and renal disease and frailty, which has been ignored for a long time. So this is to tell you that young type 2 are now in a guideline. Okay? So in young onset, if you're diagnosed, first of all, across the group, for most people, if you're diagnosed with type 2 diabetes, in the past they say stop at metformin, yeah, and then wait for a few years, and then maybe add in some urea. Wait for another few years, we add in another one, and before you know it, several years has passed, and the sugar control has escaped. Yeah, there's always a treatment inertia whereby there's always a lag time for the primary care or doctors to react to the rise of HbA1c with intensification of the treatment. It's well known. So we wanted to avoid that. So we basically now recommend dual therapy from the start, from get-go. So it's metformin and SGLT2 inhibitors from diagnosis, dual therapy. And then in certain subgroups, GLP-1 agonists can be started at diagnosis as well as triple therapy. Okay, so if you've got type 2 diabetes with heart disease, we actually say you should start metformin, SGLT2 inhibitors, and Ozempic 3. Never been done before. Yeah, and I don't think the European guidelines do that either. So we have been very proactive with that. But across the board, dual therapy and young type 2s, as you can see, GLP is now moved up after the second line. Before it was down to fourth line. So it's a huge change. And next one, I'm going to show you the South Yorkshire ICB guideline for young type 2, which I wrote with my colleagues in the ICB. And essentially, we wanted to sort of give guidance to not just to doctors like us, but also primary care and practitioners. And we're emphasizing non-therapeutic issues as well, like lifestyle, yeah, pathway to remission, weight management, structured education, dietetics, for example. Yeah. Focus on it first, and also give guidance about getting the right diagnosis, what to test to do. Once achieve that, then we talk about medications, which essentially mirrors the NICE guidance. So to sort of conclude, young type 2 is not a benign condition. And it has a lot of ramification at the personal level, societal level, and it's very expensive condition as well for the society. I think the future research and funding should actually focus on what is the best care model that will deliver, that improves the standard, that is culture sensitive, also clinical responsive. It's not just bad news. I think I've just shown you is that the wind of change has blown. There's now interest nationally at NDA, NHS England, and NICE has now got a guideline for the first time in young type 2 diabetes. And the rest totally change from the previous. Moving, we are using more and more of the so-called expensive drugs, SGLT inhibitors and GLP agonists high up in the treatment pathway. The SU, sulfonylureas, the gliptins, the TZDs, hydroxyzone are pushing downwards. So we're using the top three is metformin, gliflozin, GLP. Reason being, it can lower the sugars, of course, but also it does not cause hypoglycemia. And more importantly, it protects hearts and kidneys and improves prognosis and longevity. I'm happy to stop and take questions.
What are the risks with GLP-1s? That's what we get asked when we get asked by some type 2s if we're like doing some stuff in the community. They say, "Oh, I don't want to go on that because of the risk." And
Yeah. The GLP-1s that we use now is Ozempic, semaglutide, and Mounjaro. The rest are history. Okay. The major risk side effects is basically nausea, vomiting, and diarrhea. Yeah. From my experience, using Mounjaro compared to Ozempic, Mounjaro seems to be more cleaner drug to use. More people tolerate that. Whereas semaglutide, when we used it, I get impressions more people tend to suffer from nausea and vomiting. Yeah. So to answer your question, the most common side effects is gut, GI, nausea, vomiting, and diarrhea. But the more important side effect to think about is acute pancreatitis. Because GLP-1 agonists, including Mounjaro, which is dual GLP and GIP agonists, are linked with pancreatitis. So if you've got bellyache or severe bellyache, please see a GP because this could be acute pancreatitis.
how common is that?
I can't give you figures. It's uncommon. We see it occasionally, but it's something we need to raise the awareness among patients when we go on this road because it can be potentially fatal. The same thing applies for SGLT with DKA. So this is a real problem now. Not real problem, but real issue because we are pushing using glyphosines hotline, with metformin. So more and more people are going to be ended on this medication, and they're going to be initiating primary care for people like you. So the sick day rules and sick day counseling is key for SGLT inhibitors because we are seeing people coming through the A&E at the Northern General with type 2 diabetes and DKA, and 1 in 3 of this cohort were on SGLT. It's published data.
Yeah. Why are they getting DKA?
I think if you're unwell, if you're type 2 unwell with any acute illness, if you're not eating, they might be vomiting, they might be dehydrated, they might be hypotensive, and then if they catabolic, you're burning off your proteins as well.
So that increases
the risk of DKA. And the other thing is that if you're going for low calorie diet, you lose weight, you should not be using SGLT inhibitors as well, because that can increase the risk of DKA. Third cohort is that if you're going for surgery, elective surgery, hip surgery, or surgery you're going to have, you should stop taking it as well for at least 2 days or 3 days. Again, if you take the medication, go for surgery, you can induce DKA. So I've seen it in my practice whereby patients who went for hip replacement or knee, one of those two, by orthopedic surgeons 3 years ago, and she was taking double glyphosate. She gave it DKA. Well, DKA occurred post-operative.
What does TKA stand for?
Diabetic ketoacidosis.
Is that small with type 1 and type 2?
Yes, DKA occurred in both type 1 and type 2. Both. Yeah. So it's conditional by the diabetes gets out of control. The body breaks down the proteins, they form ketones, and then ketones are acids and become acidic, and it can lead to ketoacidosis. It can be fatal. Any questions on the NICE guidance? Any issues on?
Will you tell us what they say about monitors?
You mean the CGMs?
Yes.
Yeah. Okay. The NICE guidance for CGM came in 2022, and we basically say that for type 1 diabetes, everyone can get it. For type 2 diabetes, only a certain cohort can get it, and we are defined by patients on multiple insulin therapy with severe hypoglycemia, impaired awareness, or if they have learning difficulties or cognitive impairment, whereby they can self-monitor. And the other cohort is that if you're testing yourself at least 8 times a day and on multiple insulin therapy, then you should be given CGM as well. why do we say give everyone with type 1? Because it was cost effective. When we look at analysis of data, and the other thing is, a lot of studies been done in type 1 diabetes CGM. Yeah. And there was a lot of data to look at, and we did health economic analysis, and it was cheap to use it in long term. That's why everyone type 1 got it. Before that, it was curtailed. Yeah. For type 2, unfortunately, we could not advocate using widely on insulin treated patients because there was not enough evidence to support the stance. So we actually said that actually, you know, if you're type 2 on insulin multiple injections, you also do benefit, but we have to caveat it to a certain cohort, some group, but awareness and hypoglycemia as well. So all is about data. So I think with type 2 CGM, that's going to come next few years because most of the studies are now being done in type 2 diabetes using CGMs. That's obviously the bigger population, isn't it? Yeah. And you know, and type 2 diabetes, we do get hypoglycemia insulin. And we do know from studies been shown so far, people on type 2 diabetes on CGM do benefit as well, similar to type 1 diabetes.
What sort of time scale do you think for that?
Hopefully the next 2, 3, 4 years, hopefully, or hopefully within the next 5 years. It makes sense to use it.
Yeah.
And then there's more studies looking on hybrid closed loop.
What's that? Sorry?
Hybrid closed loop pumps. Yeah. Are you on HCl pumps? Whereby the pump talks to your CGM.
Just go.
They got algorithm, okay, and then they will give the right amount of insulin to control sugars. Yeah. The Cambridge group has done a study on HCl on type 2 diabetes and showed that they also benefited. So I think with time, the HCl will be the standard treatment for type 1 diabetes. I think that's the end game here. And for type 2, if you're on basal insulin or multiple insulin injections or on insulin therapy, I think with hypoglycemia included, then I think HCl eventually will come from type 2 as well. It's all about funding and how much it will cost. Okay. For NICE, the key factor is evidence, the magnitude of the positive outcomes you want to achieve, and how expensive or how cheap the medication is. If that's the, so break it down in simple terms, this is what we look at. If you got good data, if the benefit is big and it's not too expensive, then I think you want to win it.
When do you think they'll start changing from the HbA1c to a younger age? When do you think they'll do that? You said it's only at 40 they do it, right?
Yeah, I'm not familiar with the screening policy for diabetes.
It sounds scary, really. When you talk about these 18, yeah.
As I said, you know, if you have a national screening program, I think the key thing is it affordable? One. Number two, can you detect the number of patients in the number that will make a difference? If it's small number, a lot of effort is not cost effective. It has to be cost effective as well.
Is that HbA1c expensive, that test?
It's not expensive. I can't tell how much it is, but it's not expensive.
38p.
38p.
Yeah.
There you are.
If you,
Cheaper than paracetamol.
It's scary, isn't it?
Yeah. So I think you know, the outlook for the type 2 diabetes is getting better. Type 1, you're already there almost. With technology, CGM, you know, type 1 is Rolls Royce really for that. Type 2 is still playing catch up. But for me, the way I'm seeing it is, yeah, I think technology is important. But I think for me, it's more important to put a person with type 2 diabetes on the right medication that will improve their sugar control for a longer period, but also improve their life expectancy by reducing the cardiovascular complications using the right medication. So GLP and SGLT are top guns. It's far more important than using CGM.
Yeah.
So I think the landscape is changing. I think there's hope. We now got medication that will actually save lives for type 2 diabetes. in the past, it's only metformin, sulfonylurea, and insulin. Then EZD came along, and that was useless as well. So GLP and SGLT inhibitors are game changers. This has changed the way we see things, and that's why NICE have decided to actually look at the whole thing differently. And this is what we came up with. I hope this will be accepted. I think from the consultation that we received, we didn't get that many comments. 700 comments in total. To me, it's quite a lot, but actually they say it's quite a few because you usually get a few thousand comments. And quite a few people saying they were complimentary of the approach that we use.
Fingers crossed.
Yeah. So it's going to hopefully publish in February 2026 in the just over 2 months. So look at it. I mean, if you read the NICE draft, a NICE guide is quite dry, isn't it? I think the key things to look at the visual aid just show. It gives the subgroups easy to look down, what command can use, and the pathway.
Okay, online questions?
Yeah.
Can I just say one thing relevant to that, the screening? Diabetes UK are doing something called an ELSA study, which is screening children between 3 and 13, 20,000 children for type 1 diabetes. The antibodies, which is how they know it's type 1 versus type 2, which is hopefully going to become a national programme once this study is completed. So that will be the key. They'll target people with family history.
And you're doing that now?
Me personally, but
No,
yeah, Diabetes UK are doing it now. Yeah.
Oh wow!
I think it started in 2024. So that and I think that would help. Like I was diagnosed at 28 with type 1.
Oh wow!
And I had symptoms for 5 years, but I would have had antibodies in my system for however long. And if I'd have been in part of testing, maybe it would have been picked up before I went into DKA.
Wow.
There's an adult one as well, isn't there? Tidra. Right. So that's from adults 18 onwards.
So I think that, and that would save a lot of this. I lost 2 years of my life.
So how do people get screened then? Because I'm not familiar. I know about screening, for type 1, but how do people get their kids screened?
You get symptoms of just diabetes. You go to the doctor. Your parents take you to the doctor, or you go yourself.
Right.
And they test. They go, oh, might be diabetes if they're weaning a lot, and then test your blood sugar and send you to A&E.
That's diagnosis though, isn't
It's
it?
diagnosis.
The screening.
Oh,
How
so
is
this
it doing
health
that?
thing. You have to find out.
Yeah, screening is basically, because 3 stages, stage 1, 2, and 3. Stage 3 is clinical diabetes when they come to us. Stage 1, basically, across 3 stages, they got autoimmune antibodies. Yeah. Stage 1 is normal sugars. Stage 2, high pre-diabetes. Stage 3 is diabetes. So I think a screening for stage 1, stage 2. But I'm just wondering, how do people access that?
So if you look online,
Yeah.
ELSA, like you said, it's children 3 to 13. Well, I'm looking to extend that. And then adults is Tidra. And basically just Google it, and then basically on the website you then register. And we did it with my son actually, and you basically get a kit. You basically prick your finger. You put your finger on 5 blob things, circles. You then send it in the post, and then a month or so later you get a letter through the post. So we got a letter to say my son is negative, but that does not mean that one day he may develop it, like he could develop it. The likelihood right now is he's got nothing, which is great. But as you just said, the stage 1, stage 2, and then stage 3. Stage 3 is when you type 1. So stage 1, you've got 1 antibody. Stage 2, you've got more antibodies. And if you do get into any of them stages, you'll then be assigned a team, and they'll monitor you, and you'll have annually checks. And then there's other things that are hopefully coming where they can hopefully delay the onset of type 1. But that's another thing.
There's a medication,
yeah. But that
slows it down.
Yeah, I think it's part of NICE comment.
Yes, they are going to publish the outcome decision next week.
Yes,
Next
yeah,
Wednesday.
yeah.
Yeah.
But basically with the studies, it's basically to, you know, have a softer landing into potentially diabetes. Because like you say, you could, like when I was diagnosed at 18, you know, I was lucky my mum finally like clicked. She like, something's not right. And she came in my room and she smelled the pear drops. Like, and if that's like the high ketones, isn't it? So, because she knew there was, there's something wrong. She's like, you're 17, right? You're going to the toilet a lot, drinking a lot, you've lost a bit of weight. I wasn't fat. And if anything, I was like, oh my God, I've lost a bit of weight. I look good. But she's like, no. But her dad had type 1 about 18 years before, and it was so different. And luckily, as soon as she smelled that, like the smell, she knew. Because when I went in hospital, they were like, you know, you've been days from like PK, and you know, you hear so many stories about people who go into hospital really, really poorly or worse. So that's where the study is, isn't it? To try and help that softer landing and educate people. So if you are stage 1, then you're aware of signs and symptoms. It's like you just said, when you're stage 1, your levels are normal and you won't have signs and symptoms. But when you get to stage 2, you then may start developing, and that's where the education comes in. Because then as soon as you start realizing the 4Ts, then you can then, you know, get straight back to your hospital or GP. But I don't know about type 2. I don't know if there's a screening program for type 2. I don't think there is, but I presume in the future, evidence, data and all that and all the stuff, whether in the future they may, you know, but that could be 10 years, I don't know.
So the antibodies just for type 1 or is it type 2 as well?
Got positive antibodies in just type 1. And for young person with type
They want
diabetes,
They want to check it.
we check it now. Because we found that we look at type 2 and then we check the antibodies, they could be type 1. And then we had another patient under my care in Northern, whereby he came in with DKA actually. He was diagnosed with type 2 diabetes 10 years ago.
Really?
He's, 10 years ago was type 2 because of his age.
Yeah.
And then came with DKA, you know, and check the antibodies and type.
If I put the lights on, will it affect people online?
No, not particularly. It's more for seeing the PowerPoints.
Yeah.
Yeah.
So,
I was diagnosed as type 2 30 years ago.
Yeah,
I've recently been re-diagnosed with type 1.
yeah. I think you know, the thing is the medicine, the practice of medicine have changed. So what we do has changed. If you ask me 10 years ago, would I routinely check antibodies for newly diagnosed diabetes patients? Answer is no. What we tend to do in the past is, oh, you're a certain age, this is probably going to be type 2. Yeah, and we treat as type 2. And that was accepted practice then. Yeah, but things have changed. I think the awareness of these different types of diabetes have changed, the tactics change, and we now the tests are now much more available. So we're using it now. It's not expensive, you know, and it's very important to know where to start with type 2, because in the past, type 1 and type 2, the treatment is not that hugely important. You know, you can end up insulin happens. But now with type 2, you are putting on a certain medication that will save lives. If you're type 1, you're not supposed to get those medications. Like HM2 inhibitors, we will not use in type 1 because it can cause DKA. Yeah. So it's important to get it right. So things have changed so much in the last 10 years.
What do you think comes after hybrid closed loop? What comes after hybrid closed loop? Will it be fully closed loop and then?
Yeah, I
do
mean,
you
the
think
end
there'll be a
game,
cure?
the end game is fully closed loop, whereby basically artificial pancreas that takes away the human factor. You just let it run and hopefully it works. And don't cause hypoglycemia. That's end game. I think they're working on this now. It's obvious.
Yes, I've got an, what are the at-risk groups in young people for type 2?
BMI, family history, ethnicity.
Right.
Top three.
And you've got a global picture of young people with type 2. Is there are there common factors around the globe with young people with type 2?
Yeah, it's raised BMI.
Raised BMI.
That's a major factor. We have studies from Europe, UK, China, Hong Kong, Australia, India, US. The common factor is BMI.
Right.
I didn't show you a slide, which was done in US 25 years ago, whereby if you look at age of diagnosis, and BMI, the younger you're diagnosed with type 2, BMI goes up. It's a huge curve. It was so obvious, So BMI is the main driving factor. Obviously, it's genetic factor as well, but BMI is the main factor driving it.
Are PCNs and doctors aware of this?
Yeah, they know it because we have been doing type 2 diabetes education in Sheffield and South Yorkshire as well. With the T2Day program that led on, we actually have webinars, conferences to teach, and then clinical patients that come to see me, young type 2s, we highlighted all these risk factors. They don't know that.
When you see people without type 2 and they become type 1, is that because they didn't check for the
Antibodies.
Yeah.
So the patient I spoke about,
10
years ago, he was diagnosed as type 2 because they didn't do any antibodies.
Yeah.
But because he presented DKA, we checked the antibodies then. It was strongly positive. So there's no doubt if the antibodies was checked 10 years ago, he'll be positive as well.
I'm just not sure whether type 2 diabetes can eventually burn out your pancreas and become type 1.
Yes, it can.
Okay, that's not as common as the
Type 2 is very heterogeneous group.
heterogeneous meaning.
It's very mixed in terms of their insulin resistance and also in terms of their ability to produce insulin for own pancreas. So once there are 5 or 6 subgroups, one end is very insulin resistant group, and they got decent beta cell function. And at the extreme end, they tend to be leaner and they tend to be beta cell deficient. So they produce less insulin. So you can get insulin deficiency in type 2 as well. It's a gradient.
There's less of the other type of beta.
The main thing that differentiates between type 2 and type 1 is the antibodies, because antibodies signifies autoimmune process. Whereas type 2 is not autoimmune. And any more questions?
I think it'd be fascinating personally.
Thank you.
I just wonder, does everyone know that ABBA, Libra, you can have a 2-week CGM
Trial,
monitor for a trial if you're diagnosed with diabetes. And I mean, Vanessa is online. She's told so many people to get this and has found it's really massively changed people's lives because they can see their own life in action represented in their blood sugar.
Is this for type 2 or type 1 patients?
Oh, she type 2.
Yeah, I think CGM is equally useful for type 2 who are not on insulin therapy. Use it for a different reason here. Use it to see the impact of the food on your sugars. It educates you on the kind of food you should be not eating. And also, you also look at how your body responds to exercise. Why I say that? Because I had a CGM fitted. When it first came out, I thought I'd just try because I want to know how it feels like. We have patients on CGM, I need to know how it feels like. So I actually wore it for 1-2 weeks, sleeper. And I looked at the sugars when I have my food, and then I look at the sugars when I go for a walk. It's quite eye-opening.
That's why I did the exact same thing as you. And I couldn't believe when I went to the gym as well. So it goes down.
Yeah, because it actually informs you and gives you more information on your lifestyle activities and its impact on your glycemia and sugar level. And that's very important.
Absolutely.
Because some people see it, actually make changes to lifestyle and get the sugars down. So I think it benefits everyone, might be, whether you're insulin or not, or whether you're peptide or peptide. I don't think it matters.
Would have been interesting to see to try a little bit more on diabetic.
Yeah.
To be able to compare. Now it's just like, well, I imagine it probably would have been still up and down, but
Yeah.
within range.
Correct, yeah, I think for
It's not
type,
raving for.
yeah, for type 1, I think in the first 2 years, your glycemia will be quite stable. Because it's called period, and reason being because it's still got some insulin secretion. Yeah, not much, but it's still got some. But once insulin actually burns out totally or negligible, that's when the sugar starts to swing.
I think that mine is probably gone.
Yeah, because the younger you're diagnosed with diabetes, the autoimmune process is more aggressive.
Oh, really?
Yeah, it's more aggressive compared to older type 1. Yeah. So they burn out their beta cell far more quickly and end up in severe insulin deficiency earlier compared to older type 1.
And there's no way they can sort of mediate that.
No, it's just the biology of the condition.
There is a medication. Yeah, the nice letter.
Thank
you. Sorry.
Thank you for coming.
All right.
So I've got a question online,
Yeah.
someone who's pre-diabetic, obese and hypertensive, and is GLP-1 worth thinking about? to Make change easier or more likely?
GLP-1 actually is not licensed for pre-diabetes at the moment.
Right.
Yeah. But if you think of logically the way how GLP-1 works, I think it can benefit. You know the sugars, but also it can reduce the weight, and therefore it should improve the glycemic control and hopefully delay the onset of type 2 diabetes. So I think if you think it intuitively and logically, I think it should work. But unfortunately, it's not licensed to type 2.
It
Pre-diabetes.
But it is licensed for people overweight, isn't it?
It is.
Yeah, so
Yeah.
they would fit.
For obesity, yeah. For obesity, non-diabetic, yes.
Yeah,
But if you look at pre-diabetes, no.
Yeah.
But I think if you look at overweight or obese patients, I'm sure some of them will be pre-diabetic.
yeah. Could I take a photograph of everyone who presented this evening? Are there any more online questions, David?
I think I've got them all. I think I've got them all. Yeah, I think I've got them all. I'll stop recording.
Ask the people online.
Oh, okay. All right, this is got any message. One more question about fasting insulin. Oh, fasting insulin. Quite a bit. What about adding fasting insulin as a test available on NHS to try to reduce progression to pre-diabetes?
No.
Not available.
We don't use that test.
Right.
For pre-diabetes, we use HbA1c. That's the outcome we look for. Insulin levels does not give us much, and it's going to be raised anyway.
Yeah.
So it doesn't gives us any information that's useful.
Right. Okay. And we got several people saying thank you very much.
Oh, thank you.